But I want to welcome everyone and thank you for joining us on today's webinar, No Do-Overs, How Preparation, Precision, and Mindset Drive EMS Excellence with Handtevy. EMS, there's no do-overs. When the stakes are the highest and seconds count, clinical expertise and preparation and confidence aren't optional, they're essential. That's exactly what we're here to talk about today. Dr. Antevy will be sharing never-before-seen data that has the potential to change how we respond to and treat these emergencies and ultimately how we improve outcomes for our patients. Before we get started, a couple quick housekeeping items. Please stay muted throughout the session to avoid background noise. We want this to be interactive, so please drop your questions in the chat. We'll be responding there during the webinar. And we're hoping if time allows, we'll close with some live Q&A for a deep dive at the end. We're excited for what's ahead, and we're glad you're here. Over to you, Dr. Antevy.
All right, Dan, thank you so much. Welcome, everybody. So happy that you could join us today. My name is Peter Antevy. I'm a medical director down here in South Florida, and I'm excited about today because there's a lot of new data I'm going to present today. But really, you know, as I've done this now for an EMS for 15 years, pediatric ER for 25 years, I'm starting to really hone in on what really matters. Many of you know that I made a tenfold medication error back in 2005, and I became fixated on the math, right? And I started to understand that maybe I just didn't have to do math anymore, and that really did help me. But then I've really understood it now on a much deeper level, and that level is the fact that getting rid of the math is step one. That's the table stakes. That opens the door for you to walk through and actually treat people the right way, to actually look at mom and dad in the eyes, to actually, not be nervous, not have your palms sweating like my palms used to sweat for many years in the pediatric ER. So having an app, having the doses, yeah, that's great and it's important, but that's just the first step. And what we've been able to at least see across the country, I've been able to see in my departments, is that you can have a mindset shift, but it's got to go beyond having something that just gives you the dosing. And that's going to be the point of today. We're going to go through a lot of data. There's a lot of people on this call who I know personally who have done the work, and all of you who are on the call who have done the work, who have gotten the results, you'll know exactly what I'm talking about. For those of you who are new, welcome, and let's get started. This all started because I made a tenfold medication error in 2005, and I vowed that it would never happen to anybody else again. Never intended to start a company. But when I look now at our footprint, all the state partnerships that we have, and I know that we have several of our state partners on here today, I'm just very humbled. But every day that I wake up in the morning, it's to make sure that nobody else makes the same mistake that I did, right? And I was trained at 2 of the top 10 children's hospitals. It didn't matter at the end of the day. It matters that you shouldn't be doing math, and you have to have the mindset for confidence in EMS and what you do every single day. So let's kind of talk into why are pediatric calls so difficult. And before I give you the new data, I want to go old school a little bit, because I really want to focus in on the fact that pediatrics doesn't start when you get on scene. And that took me a long time to figure out, that your brain gets going way before you're even in front of the patient. Your brain in the ER gets going way before EMS has arrived with the patient. And it turns out that the difficulty in pediatric care can be solved before you get to the patient. It has to be solved before you get to the patient. And I want to take a little bit of a deeper dive into that aspect before we get into some of the data and some cases. As far as call volume is concerned, I just pulled this up recently from my department, because I wanted just to show everybody that your department, my department, it's probably all the same, where adults is 90% of what you'll see, pediatrics is only 10% of what you'll see. And you can see that in my department here in Coral Springs, it was 10%, in Davie, it was 8%. And then imagine how many of those kids actually have something that you need to treat. It's even a fraction of that. So this is what we call the halo event, high acuity, low occurrence event. This is what I call a call that will define a career. And we've all seen it. Unfortunately, we've had some suicides here in the last couple of months that have really impacted all of us. So the mental health is really important as well as you're thinking through pediatric care. I do have a video, and for those people who may get triggered by it, maybe now's the time to turn off the volume or turn away. This is a mock video, but the reason I'm showing you the video is because I want everyone to understand that this child who's in cardiac arrest is going to get help from other people before EMS gets there. But then as you're seeing this, I want you to think of what you're going to do in that 6 to 8 minutes en route to this call. That's going to be where the magic happens.
All right, come on. Gently, gently. All right, gently. Okay, come on.
Hello. Yes.
All right, what's up?
We had a kid drown in the hot tub.
James, can you hear me?
Okay, so if I stop you right now and I say, the tones go off at your station, you have a 7-year-old in cardiac arrest from a drowning, right? Right at that moment, that's when it's game on. It doesn't start when you get to the scene. It doesn't start when you're measuring the child. It absolutely doesn't start there. It starts from the moment I just said 7-year-old cardiac arrest, 7-year-old drowning, 2-year-old seizure, 18-year-old hypoglycemic. It doesn't really matter what it is, but it starts as soon as you hear that call. So I'm going to give you an example. All of you, and again, I know we're not in a room together, although I can see some of you. If I give you a case of a 49-year-old male, he's stable SVT. Just start to think of what things are going through your mind as you're seeing that in your head. And most of you, I'll guarantee most of you are thinking, okay, vagal maneuver didn't work. Start an IV, give adenosine. All right, that didn't work. I'll give adenosine again. All right, now he's unstable. All right, let's cardiovert. No problem. Maybe we'll give him some fentanyl before that. Cardiovert the guy. It works. He's hypotensive. Let's give him saline, standard bolus. Now he's throwing up. Or let's give him some Zofran. Right? That wasn't hard. All of you on this call could have done that with your eyes closed. And notice, all I gave you was an age and a diagnosis. That's it. Right? Now, same exact case, 2-year-old SVT. What just happened there? For most of you, you're saying 2-year-old, okay, I need a weight. All right, I'll give you a weight, 12 kilos. So when they told us years ago that they needed a weight, that was not true. What is true is that this 2-year-old also needs treatment. This 2-year-old also needs, let's say, adenosine, fentanyl, cardioversion, normal saline, and Zofran, right? Now imagine for the next 6 to 8 minutes, you're en route to a call of a 2-year-old, and I even told you it was SVT. What your brain does to you, it says, wait a minute, I've been told I need a weight, and therefore we need to wait until I get to the scene. And then the expectations are that you're going to do the dosing there. It turns out that theory is completely wrong. And once you understand where that theory comes from and you can get rid of it, then it unlocks a lot of things. So let's go a little further deeper into what the differentiator is between that adult case with these medications and this pediatric case with the same exact medications. And Ryan Gentilcore, he may or may not be on the call today, but there was a few years ago, I asked him to go through PALS and ACLS, at the same exact time. And I said, report back to me, what are the differences in the protocols? And he came back to me and he says, only one difference, which was the symptomatic bradycardia protocol. So when you look at all these things, cardiac arrest, seizure, hypoglycemia, I would love to give you my protocols where we have only one section. We don't have a pediatric and adult section. Everyone is on the same section. So seizure, there's adult and peds. Hypoglycemia, adult and peds. Cardiac arrest, adult and peds. We've taken away this theory that kids are different because except for the physiology and the anatomy, we get that part. The protocols are pretty much the same. So when I initially asked you what the difference is between the 49-year-old on the left and the 2-year-old right there in the middle, most people want to say that, kids are different. I need a weight, the whole thing. We need to really flip that on its head and remove this concept that we need a child's weight and we have to wait till we get to the scene. That's really where the errors have happened. So there's an actual reason why you feel very comfortable with the adult, and there's a real reason why you feel uncomfortable with the kids. And I'm going to go deeper into that thought process by talking about a book that I've spoken about for many, many years. I haven't really talked about this book in a long time, except for my talk in Vegas yesterday, which is why I'm bringing it back today, which is Daniel Kahneman's Thinking Fast and Slow. You really have to read the book, or just go on YouTube and watch a few of his talks. But Daniel Kahneman will explain in very simple terms why we feel the way that we do about pediatrics, even though he doesn't talk about medicine at all. So I'm going to explain it to you, and these couple of slides will unlock pediatrics at your department. It unlocked it for me, and it enabled me to help others kind of get to the promised land. So Kahneman talks about two parts of your brain. System 1, which is the fast part. It's the part where if I say 2 + 2, it's 4, right? And I'm going to give you a couple of System 1 things. The great thing about System 1, it's fast. The bad thing about System 1, it makes mistakes, and it doesn't know it made those mistakes. So just remember that System 1 will make mistakes. You will not think you made that mistake, and then you'll actually, let's say, give the drug, and you'll go on your way without recognizing that you gave a big error, just like I did. System 2, he describes, is very different. It's very slow, it's very thoughtful, and in his research, he showed that when you're in System 2 thinking, he shows the person's eyes go up and to the right, the eyes dilate, and they basically have no idea what's happening here in front of them. So if you're in System 2 thinking, you're not really present with what's going on. So all of you on the call who joined today, you're all System 1 people. I'm a System 1 person. To be System 2, it's more like a person who is in mathematics, someone who's kind of in a situation where they have to do more complex math, etc. System 2 does not belong in healthcare, it turns out. But let me show you where it's all over this thing called pediatrics. So let's go to some System 1 things. If I ask you which line is longer, some of you may have seen this already, and you know that the top one and the bottom one are the same exact length, but your System 1 wants to jump to the top one, right? But it's not. The good thing is that System 1 will never get this one wrong ever again. It'll know for next time that it was tricked this time, and it'll never get it wrong the next time. When it comes to assessment, as I put these kids on the screen, look how fast your brain knew that these kids, the first one was not sick and the last two were sick, right? It automatically knew that. The System 1 assessment is really fast. And just as a joke, I like to put this one as a sick or not sick, Mr. Charlie Sheen. He's still alive, actually. He's doing pretty well. So System 1, very good at assessment, makes quick decisions. But remember what I told you, it makes mistakes. And that's what I want to show you next. So again, we're not in a live audience, but if I had to guess, a lot of you are saying 2 or 1 of each kind. And then a few of you are saying, no, I got this one because Moses wasn't, this is called the Moses illusion because it wasn't Moses on the ark. It was Noah on the ark, right? So the brain saw animals, it saw ark, it said 2, next question. So this is in Kahneman's book called The Moses Illusion. And he shows that System 1 will jump at an answer, think it got it right, and be so confident unless it's pointed out that it was wrong. So Moses, in this particular case, is not the right character. This is where the Moses illusion comes into place, where System 1 errors come into place. You have a patient here, and these were both case reports. Patient who was vomiting, got Zofran, but ended up having significantly abnormal vital signs after they got the medication. Here's another patient who had an open fracture, got a medication, and became paralyzed. And you can see why these two issues happened. These were both System 1 mistakes. And the only reason they found this out is because someone picked up the vial and said, oh crap, we gave the wrong drug. So again, when you're in the back of an ambulance, when you're in the emergency department, and you're making a System 1 error, the chances are you don't know you're making it. Just like I didn't know I made my error initially until I figured it out pretty quickly. Once the mother kept saying, why is my kid's heart rate so high? Why is the blood pressure so high? Why is this thing ringing all the time? That's when I realized I'd given 10 times more epi than I should have. System 1 error. So this is my favorite System 1 thing. And for people who have seen me, who have known me for many years, know that many, many years ago, we used to talk about this particular item. And I'm going to do it here today, which is I'm going to give you a bunch of math, a bunch of numbers, very easy, like first grade math, and you're going to try and give an answer. So let's just play along and open up your chat. As soon as the numbers disappear, tell me with a number in the that you've added up all these numbers. Let's go. All right, let's give it a second. I know some of you know the number, but a lot of 6,000. There we go. Mohammed, there we go. George, Troy, Matt. All right. So I see a few of you are saying 5,100, right? But it turns out that a majority of people say 6,000, when indeed it's not 6,000. It's nowhere near 6,000. So imagine what just happened. You're in the back of the ambulance. Someone says, hey, George, I need some fentanyl, right? You do the math. Your eyes go up and to the right. Your eyes dilate. You figure out a number. You do the quick math you just did. You give the volume. How are you going to document that volume in your EPCR? I'll tell you. You are going to, let's say an hour later, open up the tablet. You're going to say, hey, how old was that kid? 5 years old. What did he weigh? About 20 kilos. So how much did we give him? I don't know. A mic per kilo, 20 mics? 20 mics. So the volume you gave and the number you documented, not even close, because they're not being done at the same time, right? So when in reality, what happened was, for the people who got 5,100, you got it right. But this was a System 1 error. This is any math done on scene, any math done in stressful situations will give you a System 1 error. So 30 and 20 and 40 and 10 is 100, plus 5,000 is 5,100. Now I've over the last 15 years, I've shown this many, many times, and 90% of the people in the room say 6,000, and it's just proof. This is in Kahneman's book. I didn't make this up. This is just proof that System 1 makes errors, especially when under stress. So now we talk about pediatrics is all System 2, and here is the problem. If there's one thing I can go to the people who are in the ivory towers and tell them one thing, which is the key to solving the pediatrics problem is to get rid of this thing we call System 2 thinking. So here's why. I'm going to give you a math problem. I want all of you to try and guess it in the chat. Here we go. Ready? Go ahead. So what just happened there is that some of you looked at this and said, there's no way I'm doing that. Like, I'm going to wait till the next person puts it in the chat. And what you have to remember, and I remember being in Boston, and I'm not sure if Mark and Rob are on the call, but there was a guy in the back of the room who said, hey, doc, it's at least 240, right? So at least he's never going to overdose. He'll only underdose. So the thing is that if you're in the middle of a code and I say, hey, Dan, what's 24 times 13? And your eyes have to go up and to the right, your eyes dilate, you start to ignore what's going on in front of you. What happens, according to Kahneman, is you go into fight or flight. So let me reiterate this. The minute System 2 gets activated, you go into fight or flight mode, right? So what he says is that if your gas tank was on full, like you were ready to go, right? System 2 hits, all of a sudden, your gas tank goes to empty, and then you do this, right? When is this happening? It turns out this is happening before you get to the scene. So System 2 is being activated as soon as you hear 2-year-old seizure, 5-year-old cardiac arrest. You now have 6 to 8 minutes of this, oh my God. And it turns out that when do paramedics decide to leave the scene of a pediatric arrest? And this took me a decade to figure out. You decide to leave before you get there. You decide to leave before you get there. Now, I have the standard joke that whenever I go to my mother-in-law's house, I always tell my wife, we're leaving before, like within 10 minutes of arrival. No, actually, I love my mother-in-law, but it turns out that you end up making a decision to leave the scene prior to arrival. That information is just so magical because it'll transform how you think, how you practice, how you train, and the confidence level you have. So I don't care. You can give me the smartest pediatric ER doctor in the world. I will put them in a situation. I'll just drop them in and start to ask them things, dosing, equipment sizing, drips. There's no way in the world they'll do it. And I'll send anyone a gift card if they can send me that person who can do it. And so what ends up happening when your system 2 activates is that you leave as soon as you get to the scene, you scoop and run. So if you're in an agency today where you're telling people you can't scoop and run, that doesn't work. It turns out that doesn't work. And that's really what we have figured out, within Handtevy, that it's not just an app, it's not just a dosing, it's a mindset. That's really the biggest message of today, is that it's a mindset. So this was system 1 thinking, right? And this is system 2 thinking. So if I give you even a different case, 2-year-old sepsis, walk into any ER tomorrow and say, hey, doc, I got a 2-year-old who's hypotensive, he's septic. I need normal saline dose, central line size, norepi drip, ET tube, Foley, and NG size. Watch what happens to that person. They'll get you the information, but they're not going to get it to you in a system 1 manner. So why is this important? Is because we have to figure out a way, and again, that's really what we have done without knowing what we were doing with Handtevy, is that we were just removing system 2. So now imagine this kid right here. If before you walked into that house, you knew it was 2-year-old, you had access to the saline dose, the central line size, and we're not doing a central line in EMS, but in the ER, norepi drip, ET tube, Foley, and NG. If you knew all that math beforehand, now you could walk in, you could look at mom and dad in the eyes, you can assess the patient, because that is system 1. You could make a decision on what you're going to do next, and then you're going to, in a very calm way, make that happen. With that information at hand, pediatrics becomes just like adults. And that's why I tell people that kids should be treated just like adults. That's what I mean when I say that. So before I get on to the next section, when you have adults and you have good bystander, good telephone CPR, good pre-planning, it's all system 1 all day long, you have a great outcome. In peds, the bystander CPR is worse. The telephone CPR is worse. No one's ever taught you how to pre-plan. I'm going to show you a video in a minute. Then they show up on the scene, on the curb. You're already in system 2. They throw you the kid. You run back into the ambulance and you start screaming to the hospital in full arrest. Very different than the last case of the adult. So very important to understand that the scared part, the system 2 part, happens before you arrive on scene. I just can't say that enough times because it's such an important concept. So when you look at pediatrics in your agency and you're looking at your data, looking at your outcomes, you also may want to look at what's going on with your patients and where they're being treated, how are they being treated, and it's really all psychological in nature. Now, I stole this because I was in Vegas at IAFC at Fire Rescue Med, and my good friend, he was an assistant fire chief in South County Fire, Sean Maxwell, he sent me this slide after he saw my talk. I'm like, can I steal your slide and put your picture on it? He said, yes, of course. And he said, after I saw your talk, he's like, I have a slide in my talk that says every battle is won before it is fought. Every battle is won before it's fought. And it's exactly right. So his image on the right-hand side, which is readiness, response, and resilience. And I think he should write a book on this, because the readiness part has to be there in order for the response part to go down well. And then after the call, that's when the resilience comes in. So look up Sean. I'm actually going to have him on a webinar because he's such a bright guy and he knows the meaning of human factors, especially in the field of fire and EMS. But I just thought that this concept was just so brilliant. So let's move into the data. I know I posted some things on LinkedIn the last couple of days after spending a few hours inside the new CARES data set. And I'm going to challenge you a little bit because this is not a comparison game of I'm better than you, right? I mean, the reason that I post what I post on LinkedIn is because I want to challenge people to go and look at their own data and then compare themselves to other people and then look in the mirror and say, how can we do better? What are we not doing right? And I'm going to give you some input as to what I think, where I think you can start. But there's data today that you can go get right after this call is over, asking how is your state and how does your organization compare to others? So let me show you that. You go to www.mycares.net. You can do that right this second, and you can get two things that I'm going to show you in a minute. The 2023 annual report, very nicely done. Dr. Brian McNally and his entire team at CARES, they're doing a great job. And they're actually really doing a great job on the software that's being rolled out now. So CARES is going to get even better. That's number one. Then the second thing we're going to look at today, which was just released this past week, is a 2024 non-traumatic summary report. So it's all cardiac arrest, and then we'll talk about the shockable witness as well. So what is this going to give you? It's going to give you the report of the United States. If you look at the top right, you should have access. One of you at your agency, someone has access, probably one of the chiefs, maybe the assistant chief. They have access to CARES, and that's where you go in and say, show me my data. Davie Fire Rescue, Coral Springs, Brevard County, Palm Beach Gardens. I can go in there and find that, and I'll show you that in a minute. And you could say, compare me to the state and compare me to the nation. So this is free. This can happen right now. You just have to go find the person who has the access and you say, show me the data, because that's where you start. Without knowing the data, then you really, not understanding, where you're going to go next. Okay, so this is 2023. I found this right in the CARES annual report, and then I threw it into ChatGPT to give me a nice image of it. But basically, the national average is right here. So what is this telling you? It is saying that out of hospital cardiac survival to hospital discharge, state by state, has a massive differential. And it's a massive absolute differential. So when you look at, for example, the state of Vermont, they're on 7%. But then when you look at the state of Washington, they're above 14%. That's basically double. Now, people will say you can't compare one state versus the other, but listen, it's cardiac arrest. I mean, it's very variable. There's a lot of things that can go into it. I get all that, but there is a massive disparity between here and here. Now, I'm going to show you a little later on where some of my agencies fall, and that's what I want you to do. I want you to say, okay, I see the state level data. Where's my data? If your data ends up at 5% or 3%, then the very next thing you ought to do is you ought to say, we're doing something wrong. Let's go find out what we need to do and let's go do it. Call people. I'll give you everything that you need. Everything that you need. We have them in Dropbox folders. We've made videos. You got to get better if your numbers aren't doing good. If your numbers are really good, then you don't need us. You don't need anybody. Just keep doing what you're doing and call me because I want to know what you're doing. So this is now all going to come right from the data. And I want really... I'll try to go slowly through each of these because it's really a lot of data in here. In 2024, under the age of 1 year, there were 1,525 total arrests, okay? When you look to the right and you see, did they survive to hospital admission, 264? Did they survive to hospital discharge, only 88? Did they survive neurologically normal, only 70? So the neurointact survival for infants is very low, 4.6%. But remember that number of 1,525, because a 1 year age range in pediatrics far outnumbers the collective other age ranges for pediatrics. And we've known this, that you're going to see 4 times more infants in cardiac arrest in your career than you will see the 1 to 18-year-olds. So, but these have the worst outcome. So you're going to see many more of them, and their outcomes are going to be worse. And we'll talk about why that is in a minute. Now, let's go to the pediatric 1 through 12. Remember the last number, 1525. 1 through 12 is 1,210. So now you have all these years of data with 1,210 arrests. Now, survive to admission, 426. Hospital discharge, 183. 140 survived neurologically intact, 11.6. That's actually pretty good this past year. I mean, this is it's nice that we're in double digits for pediatric neuro intact survival. I can't remember a year that adults nationally were above 10%. So again, 1 to 12, you have fewer cases than the under 1. You end up having 11.6%. But again, you only have 140 of these kids total who are normal. That's a small number. Now, let me put those side by side together just to kind of smush those two graphs together. And again, you can see more infant arrests. But now when you combine both ages, and so why did I split those two things out? Because you'll hear this. Oh, you'll say, oh, pediatrics, neuro intact survival, only 7.6%. Really a lot worse than adults. But that's why I split it out for you. And again, I did all this through ChatGPT. It took me a lot of hours because I wanted to make it into a nice display. So when you hear pediatric neuro intact survival, 7.6%, you should say, no, wait a minute. That's because the infants are dragging it down, but the pediatrics themselves are higher than 10%. They're higher than 11%, in fact. And now we're going to look at the teenager data, and you're going to say, wait a minute, that's even better. And now we're going to start to segment the population to say, we now know when we go to a certain age of a child, they may have different things wrong with them, and therefore their outcomes are better. And that's exactly what the data shows, and we're going to go through here in a minute. So let's go to the teen data, 13 through 18. Only 790 total arrests, 301 survived to hospital admission, 159 to discharge, and 129 CPC 1 or 2, giving you a 16.3% neuro intact survival. Wow, right? Now, again, if we compare this data to the adult data, you're going to see the adult data is in, over 100,000 patients. But this segment of the population comes back to a strikingly high degree. And you're probably saying to yourselves, what is going on here? Well, it's going to be very, very apparent to you very quickly in a minute. And it's going to change the way that you act within your community. It's going to change the way you respond to your community. If you're going to a high school, if you're going to a sporting event, this data should impact what you do, how you think, how you prepare, right? And that was really the goal of this today, was to say how we think about pediatrics has to change, our confidence, what we do before we get to the scene. And now I'm layering on data, real data, that's going to impact how you think about a certain age type as you're headed to that scene. That's the key here. Now, let's go to adults. You always hear the number 350,000 cardiac arrests a year. That is true. But in the United States, we only work half of those. So if you're in EMS today, you know this, that half the calls we go out to that are arrests, half of them we work and half of them are just dead. We don't do anything. So the real number is 136,785 that we worked, 35,148 survived to admission, 14,000 to discharge, 11,280 CPC 1 and 2 for a neuro intact survival of only 8.2%. Now, that's the number, the neuro intact survival, that you're going to be looking at your agency to say, hey, you know what? How do I compare with respect to neuro intact survival? That's going to be the key number that I want you guys to be looking at. Okay, so if I put all those prior graphs on one neuro intact survival chart, this is a very telling image. And what it tells you is that there's something about the teens that make them come back to life with a neuro intact survival. And in fact, yes, there is, as compared to the adults. And the adults, obviously, as many of us know, we're going on the 90-year-old who has cancer, who has a DNR, but we work them anyway. They end up in this data set. When you're talking about teens, they have very different things, and those things seem to be amenable to an EMS response and a bystander response, of course. Pediatrics, again, 1 through 12, they do better than the infants, and we're going to look at why here in a minute as well. Okay, so why do infants have worse outcomes? Well, let's take a look. This chart, again, all from CARES, shows now the percentage of shockable initial rhythms by age group. And this really tells the story, right? In infants, only 58 of those infants had a shockable rhythm initially, and the bystander AED, 0.6%. And there's a lot of reasons for that, right? When you go to pediatrics, only 70 had a shockable initial rhythm, only 70. Bystander CPR, only 2%. Now you move to the teens, 151 kids, 5.3% had an AED, still a very low number, and I'll show you a case that was just reported on LinkedIn the other day that goes along with this. And then in the adults, where you have 7.7% AED and you have 18% shockable rhythm. So look at this graphic. It tells a very, very important story, which is the story you're going to go back on your next meeting and say, if you're going to go to a teenager, be prepared. It's a shockable rhythm until proven otherwise. And that means we're going to start measuring our time to first shock. We're going to start measuring every single compression. We're going to make sure our CPR performance is high quality. We're going to make sure that we're doing 2-minute rhythm checks. We are going to make sure that we're going to give these kids the best chance of survival on the scene. And that preparation starts when? It starts before you get there. That's the key. So let's take a look at one of the final graphs here that I made out of CARES 2024 data, which is the percentage of bystander witnessed arrests, right? Obviously, when do the infant arrests happen? Those are the 7 a.m. calls. All of you know it. If you work in EMS, if you work in the emergency department, these are the kids who the parents have rolled over on them. It's a lot of co-sleeping. These are the kids who are put to sleep at night, and then they wake up in the morning and the kid's been dead for hours, right? That's why you end up having not a lot of bystander witness as compared to the other age groups. Very important. So when you're practicing that infant call, understand the type of call you're going to get. It's going to be a morning call. It's more than likely going to be, in that bucket of what infants die from, which I have a slide on in a minute. And that's what you're going to practice on. So you're not going to practice the infant in VF is what I'm trying to say to you, right? Okay, now here we go. So let's take a look at the top left box. Infants, respiratory failure. So those are the broncholytics. They have some severe viral infection that's causing them to have, apnea or some obstructive event. SUID, right? We don't call it SIDS anymore. It's a sudden, unexpected infant death. Choking and aspiration, that's that age group, right? We know that's the age group. Moving down, 1 to 12-year-olds, respiratory, the asthma-like illnesses, the infections, the pneumonias, the congenital heart defects, the arrhythmias, the traumas, the drownings, okay? Again, when you're thinking of what could be causing these problems, these are them right here. Now the teens, 13 to 18, hypertrophic cardiomyopathy, other inherited arrhythmias, commotion cordis, and drug use. Obviously, trauma will be in there too, but again, I'm staying away from the traumatic causes here in this talk. And then with the adults, it's coronary artery disease, MIs, VTVF, and heart failure. So when you look at this slide and you start to say to yourself, my goodness, these kids are dying from completely different things. Well, yes, they are. And therefore, the training, the preparation, the pre-planning, the performance on scene, the things you're focusing on when you get to the scene are different. And that's what you need to know. So I wanted to bring up this case only because somebody posted on LinkedIn that this case just got a verdict, a $15 million verdict. And so I figured it was important enough because it blended in a lot of things here, and it blends in a person who was on the Florida EMS webinar the other day, Melissa Olin, who is spectacular, who's doing something now with us in Palm Beach Gardens that I think all of us in EMS should do, which is EMS could potentially help the schools get ready for that next cardiac arrest. So let's talk about it. 13-year-old kid. He was a runner, suddenly collapsed. Apparently had a history of syncope. And unfortunately, he ended up going into VF. Now, here's the problem. The school had an AED, but no one knew where it was. Or the principal knew where it was, but nobody else knew where it was. They really didn't prepare for this case. And therefore, this kid never got what he really needed was high performance CPR and electricity, right, to get him back to life. And he ended up a child who ended up having hypertrophic cardiomyopathy. And this is important. The LA County School District, the LA Unified School District, got a verdict against them for $15 million because they weren't prepared to use a device that they had on campus. Now, how do we change that? I think that all of you on the call should be involved in this. And after I heard about Project Adam, which I'll talk about in a second, I think that all of us should be thinking about it. And that's why I'm so proud of my team at Palm Beach Gardens. And I know my chiefs are on today. This wasn't my idea, trust me. They came to me and said, why aren't we involved in Project Adam? And I said, you know what? That's the smartest thing I've ever heard. So again, preparation, planning, partnerships, collaboration. This is what's going to get more kids back to life. So I have a video. This is Melissa. She works at Nicholas Children's Hospital, but she is the point person for something called Project Adam. This is just going to be a very short video. She was on the webinar, and you can go to our YouTube channel and see the whole video. I hope that you do. But she showed a video of kids going into cardiac arrest, and just the recognition is something that she's focusing on when she goes into these schools. Let's take a look.
All right, so let's get to the business end of this. I'm sure many of you are curious. Okay, so what goes into this and how is it done? Well, the first step is that the team of all school faculty needs to know that there is a how to recognize what CPR. So it's an all staff awareness video.
Hi, everyone. I'm John Dresner, director of the UW Medicine Center for Sports Cardiology. And in the next 100 seconds, I want to show you how to recognize sudden cardiac arrest in an athlete.
He can be seen coming out of a timeout huddle, his head dropping. He stumbles, then alarmingly, he falls face first.
Here you see Keontae, head drop, stumble, sudden collapse. This is what sudden cardiac arrest in an athlete looks like.
And collapses, just like Hamlin did in sports from football, lacrosse, to baseball.
Mark Vivian Foe, he shows all the signs of sudden cardiac arrest, continued breathing after collapse, eyes open and rolled back, the face of sudden cardiac arrest. For DeMar, after his arrest, his arms go up with seizure-like activity. And for Christian Erickson, a sudden collapse, also unresponsive, eyes open, brief seizure activity in his leg. This is sudden cardiac arrest.
We've been there, but that's not a good look at all.
With Claire, dramatic episode, collapse with seizure-like activity in the arms, an amazing emergency response. Call for help, someone go get the AED.
So imagine right this second, right here in this school, all of a sudden they call 911, someone's going to get the AED. Who is responsible for organizing that? Who knows what to do? Who knows where to go? I mean, these things never happen when everybody who was trained is in the room. You have to train everybody that if this event happens, then things like all the dominoes have to start falling immediately. And that's what Project Adam does. And that's what people like Melissa Olin are doing. And now imagine that yearly training that happens, instead of Melissa going out every single time, what if she says, hey, Palm Beach Gardens, can you guys go out there and do that training? They know you, they're in your zone. Here, take this toolkit. Let's train the school on cardiac arrest response. And all of a sudden you have a collaboration. And then when EMS gets there, they already know who you are. It's a brilliant, brilliant thing. And Adam is a teenager who unfortunately passed away from sudden cardiac arrest, and his parents have created Project Adam, which is, I think, now in 49 states. What did this child die from, the 13-year-old that I just told you about? Just real quickly, it's hypertrophic cardiomyopathy, which that septum right there should be a centimeter, but in hypertrophic cardiomyopathy, for genetic reasons mainly, there's a lot of other reasons for it, but this particular child had a 5.5 centimeter septum. Now, that ends up decreasing so this is like a diastolic issue, right? Because the wall becomes so stiff that you get decreased stroke volume, reduced cardiac output. And then there are some kids that it gets so large that you end up getting hypertrophic obstructive cardiomyopathy. Either way, either of those scenarios, these kids have very high risk of going into VF. Okay. Now, if you look at sudden cardiac death in competitive athletes, 48% of the time it's HCM. 48% of the time. And by the way, if you have a kid who's an athlete, go get them an EKG. There's some telltale signs on an EKG that you can know if somebody has HCM. Okay. And now when it gets to the obstructive part, that septum, it gets so big that, you know, they're exercising now, they have increased heart rate and contractility, but now they have a decreased LV outflow because of the cardiac, because of the obstruction. The cardiac output goes down, supply doesn't meet demand, they end up having chest pain, dyspnea, they have angina, and these kids will go into cardiac arrest. That's why you see the teens, that's why you see the athletes, that's why the numbers are what you saw in the CARES data report. So let's move now into what is the secret to success? You're probably all listening to me thinking, okay, what's this guy really want us to do? And so here it is. And now I'm going to brag a little bit about some of my agencies here. So, and Dan, and I see Ryan just joined. Hey, Ryan. Dan obviously was my EMS chief at Davie Fire Rescue. So I give, you know, a lot of kudos to Dan, and now Chief Mayra, Chief Gonzalez, Lieutenant Hartman. And I have some folks here from Coral Springs. I see Chief Ippolito, Chief Lammer on the call from Palm Beach Gardens. But when I put our numbers compared to what's happening across the nation, you know, that's a comparison that I want to see. And that's what you can do today by just going on and logging into CARES and getting the right access. Again, national average 10%. You want to be at least there. But isn't it nice when you can be double of the national average? That's a lot of people. That's a lot of people. So now I'm going to brag a little bit on Davie a little bit, because when you look at this thing called Utstein, and everyone brags about, you know, their survival, but when you get to the number called Utstein, what does Utstein mean? It means out of all the arrests that you ran last year at your agency, if you only carve out the people who had a witnessed arrest and the initial rhythm was shockable, that's called Utstein survival. National average, 33.2%. You know, 66.7% is very high, right? If you're in the 50s, that's a good day. Let's go have a beer. Now, then there's something called Utstein bystander. All that means is that you're carving out now the number of patients that had a witnessed arrest, initial shockable rhythm, and they had some bystander intervention, bystander CPR or bystander AED, not by EMS, by the bystander. Those people have a higher chance of survival. So it is fair to just go and compare your Utstein data. But remember, your shockable rhythms are only 20% of your total arrest. So your Utstein data is going to be small in your community, and it's small here. It's not a big number. And so your Utstein may fluctuate one year after another, unless you're a very big agency with a lot of cardiac arrests. But on a national level, 33.2 and 37.5 is where that's at. Again, I would advise you to get somewhere try to get towards 50, 60%. How do you do that? Go back and really do the good CQI and QA on your VF calls. So the way I tell my folks is that, like, the people we really should be getting back to life are the VF cases. And those are the calls that you want to make sure you do a really good evaluation. I'm going to show you what that evaluation looks like. So first of all, because my chiefs are on the call, I want to really commend them. The IAFC, which we were just at in Vegas, and I know my chiefs are on their way back now. Also, this is sponsored by Pulse Point for great reasons. They're a great company. And here, this is a picture that was just happened a few hours ago that Chief Lamb sent me. But Sarasota Fire, congrats, in Florida, and Palm Beach Gardens received this year's award for 2025. If you're a high-performing agency, submit for this award for next year and receive the honors. And in Davie, we received it in 2020. So here's a recent case from Davie. I removed all any HIPAA-like information, but I just wanted to show you what we really do, okay? This is a case that happened a couple of weeks ago. Take a look, right? So look how quickly the machine was powered on and the first shock happened. So remember, every box is 10 seconds, right? So 10 seconds, 20 seconds. Within about 20 seconds of the machine turning on. So like, this is spectacular, right? Then we're doing rhythm checks every 2 minutes, 2 minutes, 2 minutes, 2 minutes, like clockwork. The compression rate is always between 100 and 120. And our ventilation rate, again, it started off a little slow, but then we picked it up. And then boom, look at the next slide. We got ROSC, right? Great outcome. It's the speed, it's the pre-planning, it's the training that goes into this. But how do we make that happen? Because we have someone in our department now. It was Chief Mayer, and now he's passed it on to Lieutenant Hartman. And let me show you the email that happened the very next, oh, I thought I had the email. Yeah, I do have the email coming up. But how do we do this? And here's where Handtevy, the CPR assist, comes in, where you really have to have some metronome. It's in the 2025 ILCOR guidelines. When the AHA guidelines come out, it'll be there too. You need to be using a metronome. So what we did years ago, we created a metronome that is customized to your agency. It will start at 32 for an adult, at 52 for a kid, continuous if you wanted to. And it keeps you on track. It tells you when to ventilate. If you give epi, it'll tell you when to give the next epi. If you click on defib, it tells you the defib dose. So we have now taken this feature and we've made it so ingrained in what we do every day. When people say to me, what has made the biggest difference? Yes, I have great leadership. We do great training, but we use this metronome on every single cardiac arrest, adult or kid. And then here comes the email. Okay, so again, I redacted any of the information, but this is the kind of email sent to the crew. Imagine you're a crew and you get this email from Lieutenant Hartman, and he goes through exactly, like literally minute by minute, potential opportunities, limit pauses to once every 2 minutes as directed by the app, limit pause duration to no more than 8 to 10 seconds, achievements, appears the Handtevy app CPR assist was used, chest compression fraction 92%, average compression rate, post-shock pauses were great. So this is not punitive. This is not really like a pure attaboy, but this is just, he gives them this and he says, you know what, take this back, sit with your crew, look at the case, open code stat, and then we're going to get better next time. This is how we do it. This is how it should be done. It doesn't just happen by going to a resus academy or Resuscitate Florida, which we do often. It requires this type of care and work on every single case. So 2 key elements, and I'm looking at the time here. 2 key elements. You have to have a pre-arrival plan. It has to happen before. We talked about why that is earlier. And you have to then stay on scene. And if it's cardiac arrest, it's BLS, right? Don't fool yourself. BLS is cardiac arrest, and then you sprinkle in some epinephrine. So I love this video from Urban Meyer because he talks about the pre-planning. This kind of goes into the pre-planning part of what we do. So take a listen.
Coach, one of the situations we haven't covered so far this year is hurry up offense, end of the game. Purdue was in this situation against Northwestern. They actually scored on their final drive to win the game. So if you would take us through some of your philosophies about 2 minute and how you approach it.
The most important play is the first play. How do you get it going? The most important play is the first play. How do you get it going? The most important play is the first play. How do you get it going? Purdue actually had an incomplete pass. So now there's a little bit more stress. So now there's a little bit more stress. So now there's a little bit more stress.
All right, so thank you to Captain David Cooper for making that video for me. But the first play is the most important play. That's the preparation. It's the pre-arrival. And the stress level increases when the first play goes poorly. That's exactly what we're talking about with System 1 thinking, getting rid of System 2, knowing the dosing before you get there. So how do we do that? Let me show you. Here's a video that we just created at Palm Beach County. I got to thank my amazing team there, Baggio, Muvdi, Chief Coyle, of course, Chief Oliveria. Here's a video that shows exactly how we do that. Let's take a look.
Today we're going to go over the Pediatric PIC crew pregame. Responding to this call can be one of the most stressful situations that we respond to as firefighters, EMTs, and paramedics. Just like responding to a fire, having a pregame and training can make us successful responding to this call. This doesn't just pertain to your pediatric patients, but this can be for any adult or pediatric emergency that we respond to. This can be done while you're doing your truck checkout, or this can be done at the breakfast table when we're sitting around having a cup of coffee. This is a good time to go ahead and assign roles and responsibilities and make sure your crew understands who will be position 1, the compressor, position 2, monitor, and position 3, airway. We also want to make sure that we include both units, the engine and rescue, as we will need somebody who comes in as position 4. Let's go ahead and see what this looks like.
All right, guys, we're out to 7-year-old in cardiac arrest. Patient was just pulled out of the pool by mom. Mom is currently doing compressions. Patient is not breathing. As I talked about earlier, Michael, I'm gonna have you on airway. You're gonna use a pediatric BVM with the adult end tidal, a green OPA. Your IGL size is gonna be 2.5. Baggio, I'm gonna have you on compressions.
Copy, compressions.
The combo pads I'm gonna use is adult combo pads front and back. My initial joule setting is gonna be 100 joules for the first 3. The last joule setting is gonna be 250. I'm gonna use blue IO needle, 25 millimeter, 2.5 mLs of Epi 1 and 10, and 2.5 mLs of amiodarone.
Copy, a 25 millimeter blue and a 2.5 mLs of amiodarone or 2.5 mLs of Epi.
Remember, position 2 will be responsible for placing the IO and delivering the first dose of medication after the initial first shock or dump. If this cannot be completed by the time position 2 has to take over compressions, it will be the responsibility of position 1 to finish placing the IO or deliver that first dose of medication.
It's gonna be a little bit of a hectic call because it's a young kid, so I'm gonna turn on the metronome for us.
And that's a very important aspect of the pediatric call. What you just saw there, it doesn't just start in the truck. It started from a mindset, from the leadership, down to the EMS captains, down to all of our personnel who are actually doing these hard calls that that they're having to respond to. But if you're not prepared to do what you just saw there, then you're going to end up having that high heart rate, the sweaty palms, and you're not going to be calm, and you won't be able to look at mom and dad in the eyes. So again, pediatric calls start way before you arrive on scene, and that is exactly the demonstration. And I'm so happy that my team made that video because it was, we have a lot of people asking us exactly, you just saw it. That's exactly what we do on the pediatric call. We have graphics that we can send you as far as the pit crew approach. Many of you know this, but when you see us run the pit crew, no one's talking. The equipment is put down in the exact spot. Everyone knows exactly what they're doing. And we try to get the first shock on within the first 60 seconds. And that's a metric that we follow on every single call, especially when it's a shockable rhythm. Okay, so real quick, and I see it's 2 o'clock. I'll be done here in about 5 minutes. So apologize for the overextension here. Gear placement is very important. Position 1, that's relatively straightforward. That person will compress until the pads are on, the monitor is charged, and then we do the first look, we shock or dump, and then they go right into the first 2-minute, the real first 2-minute cycle. The monitor person, that's pretty simple. The airway person, we do 2 big breaths with a BVM. We put an iGel in, right? That's our airway of choice for cardiac arrest. And then we will upgrade if needed afterwards. How should high performance CPR look in the backyard by the pool? Like this. They're not moving. They're not talking. The one thing that I would like to see here would be mom and perhaps an officer. If you're watching this saying, we only have 2 people, well, you do it with only 2 people, right? Knowing that in the infant, it's not going to be VF. It's going to be more airway. So you're going to focus on airway and chest compressions. Knowing that in the teenager, it's going to be a shockable rhythm. So you're going to focus on making sure you're getting those pads on. And by the way, we go AP first now, and we do double sequential very rapidly right after that. Okay. Now, once your department is doing this, they have the mindset, they have the confidence, strange things will happen. And I got to give kudos. In Palm Beach County, we now have 5 codes, 5. When we got to the ED with the patient, the doctor and the nurse stand back and say, you guys run the code, right? And then we transfer them to the children's hospital. That's confidence that I love to see. And by the way, it doesn't happen because I'm there saying, I'm your medical director, you better do that. It doesn't. It happens because it's a mindset that the entire department from the top down and the bottom up believes in. So again, I have to reinforce this. And, you know, we are people who put out an app, and we love the app and we think it's great, but success is a mindset. It's not just the app. Just remember that. And it has to happen before you get to the scene, and you have to have that communication and collaboration and the education to make it happen. If someone just gives you an app and says, here's all the dosing, it ain't going to work. I hate to say that. And most of you know that. Last couple of stories and then we'll end. And this was impactful for me because, you know, I've been doing this for a long time and very few people believed me early on. This guy did. He's one of my closest friends now, Dr. Mark Grossman up in New Hampshire. He's a brilliant guy, great medical director. And he says, Pete, I believe you. Come teach us. And Miami-Dade did. And really within a week after they implemented, they got on scene and they had a little boy drowning. His name was Alejandro. He was underwater for about 6 minutes. They got him out. They stayed at the poolside, and this kid ended up in the ICU. So he ended up at Jackson. This is from Jackson, intubated for quite a number of days. But then he woke up, and they extubated him, and he started looking around again. And when he went to rehab, and here's Tammy, she's from Miami-Dade, Tammy Napoles, and she actually came to visit him at the rehab center. And then he went home. Remember, this is 2014. So I went to visit Mark about a month or two ago, and I said, hey, Mark, remember this kid Alejandro? He's like, yeah, do you still have the mother's number? I said, I do. He says, call her and see if she'll send us a photo. So I called her up, and she says, hey, Doc, I remember you. And then she sent me this photo of Alejandro. This is just a couple months ago. So this is the kind of change you guys can make, right? This is EMS. This is EMS. And there's nothing that I'm more proud of, and something that at least is therapy for me as a person who has made mistakes that I regret. These are the stories that I think we can all live by. Polk County has done a great job. They actually published on Handtevy years ago because they called me and said, hey, Pete, we don't have any survivors. 38, 2 got Ross, none of them survived. We came and we taught them how to stay on scene, the mindset. You go to Polk County today, they're not leaving that scene unless they've given this kid the best chance of survival. And look at their time to epi. It went all the way down from 16.5 minutes to 5.4 minutes. By the way, you're not weighing that kid on scene. You're not bringing a scale to the scene. No, you don't need the exact weight of a child who's in cardiac arrest. You need to get there. You need to know the dose before you get there, and you need to act quickly if you want these kids to come back to life. That's the bottom line. And this was a paper in 2010. This is on our website. Please go take a look at that one. And again, they published the 2014, 2015 data, and then they keep sending us data year after year after year. It hasn't changed. So Handtevy is a mindset. Handtevy is removing system 2 using the app. Handtevy is who you become after, you know, it doesn't happen overnight. It takes 6 months, 12 months. It takes a couple of cases for you to say, you know what, we made it work. More data from Denver showing a reduction in medication errors using Handtevy. Of course, a huge, huge system of great, great people. And then I don't want to stop before ending with this story, which is a little girl, 8-year-old girl, who went to cardiac arrest in Bend, Oregon. And there's some people there who are incredible people. Peter Hosick, Amber Hosick, the entire Bend Fire Department. They stayed in this girl's house for 40 minutes, multiple rounds of defibrillation, 40 minutes. And the dad wrote on Facebook, he wrote this beautiful thing. And then he wrote to the first responders, my family's undying thanks. My family's undying thanks for never giving up on my daughter. Why? Not because they ran, because they stayed. And they stayed with confidence. And if you're a parent, you know what I'm talking about. If you're seeing someone performing something on your child, CPR, and they're good, you know it, and you're okay with them staying. And that's the girl before she was discharged. This is a life saved by the best EMS systems, right? She's perfectly normal. This never would have happened in a place that did a scoop and run, that only knew dosing. That doesn't work, right? You have to know everything. And there's Peter. I got to give credit to his beautiful wife, Amber, as well. Here's us in Palm Beach County. This little boy was in cardiac arrest. He had cardiac wall motion on an ultrasound. So our amazing EMS captain, Ada Rayburn, decided not to give a cardiac arrest dose of epi. She gave push pressor epi. Kid walked out of the hospital perfectly normal, right? This is how you do it. And then another recent case from Palm Beach where was a drowning who also got push pressor epi because he had a pulse. And we've changed our protocol. We've removed cardiac arrest epi from the symptomatic bradycardia protocol. This is on Halloween. He walked out. And I have to give kudos to Palm Beach Gardens. We had an amazing case of a 4-year-old recently, traumatic, almost arrest because they were hit from behind on 995. His femur snapped in half. He was hemorrhaging. Our EMS captain came there, gave him blood on I-95. He woke up. Halfway to the hospital, he started braiding down again, gave another 10 cc's per kilo of blood. The kid got fixed. His femur got fixed. He walked out of the hospital about 4 or 5 days later. So just incredible work. EMS is where this is all happening. So to end, and I would say to everybody that if this is your today, meaning that bystander is not any good, telephone CPR is not good, there's no pre-planning, you're rushing off the scene for kids, make this your tomorrow. We owe it to our community. We owe it to the children of our community and the adults of our community. And then start to look at your data using CARES and start to aim for the stars. That's what I would recommend that we all do. It's really a psychological thing to do. We are here to help. My entire team is here to help. And we're very grateful that you joined us today. So for the people who get upset with me when I say treat kids like adults, now you know what I mean. So with that being said, we're 9 minutes over. I appreciate everybody who stayed.